Hello everyone, this is Dr. Zien Fozo, and today we are going to discuss an important subject in the emergency medicine, which is evaluating patient with chest pain in the accident and the emergency department. Before we start, we need to set a few goals that we would aim for at the end of the lecture to be able to follow the right approach for a patient with chest pain in A&E to reach an accurate diagnosis, provided that all patients are maintained safe and stable, to refer the patient to the appropriate theater after stabilizing the patient for definitive management, to know your limits, and to escalate doubtful situations whenever applicable. First of all, we are going to establish a differential diagnosis for any patient with chest pain. Now, we are going to divide this into cardiac and non-cardiac causes. Cardiac causes would include myocardial infarction or acute coronary syndrome or angina, whether stable or unstable. Also would include pericardial effusion or pericardial tamponade and thoracic aortic dissection. Non-cardiac causes would include pulmonary embolism, pneumothorax, pleural effusion or hemothorax, also pneumonia, pleurisy, flare chest, costochondritis, and musculoskeletal pain. So to follow a few steps just to maintain systematic while assessing such patient, there are four main stations or stops where you need to think and act. The first one is to take focused history, because yet again the patient would be in pain, to do physical examination and to obtain a venous access. The second step would be to make sure that the patient is stable. The third step would be ordering and interpreting initial investigations. Lastly, you would need to refer the patient to the specialized team for definitive management plan. So we are going to follow these four stations in order. The first one is to take focus history to do the relevant examination and to secure venous access. You would then have two types of patients, either stable or unstable. If the patient is unstable, then you would need to stabilize hemodynamically and to check for underlying cause following the ALS or the ATLS approach. Today, we are going to discuss how to manage the patient if the patient is stable. So if the patient is stable, you need to order ECG and chest X-ray for the patient. Keeping in mind that you need to do ECG first to exclude any cardiac cause for the chest pain. One side note is to administer aspirin if the risk for aortic dissection is low. However, just to simplify things, we will not discuss this in details today. Now, let's assume that we already did an ECG for the patient. We need to ask ourselves, is the ECG consistent with features of acute coronary syndrome or not? Now, we have two scenarios. It might be consistent with or it's not consistent with. So if it is consistent with acute coronary syndrome, you will have two scenarios there, whether or not it's STEMI or non-STEMI. STEMI means ST elevation MI shown within the ECG, and non-STEMI means that there is features of MI but there is no ST elevation. Now, if the patient shows STEMI, you need to treat with emergency catheterization or thrombolysis therapy according to the time of the presentation of the patient. If non-STEMI, you need just to treat with appropriate anticoagulant therapy. Now, let's try to think if it's the patient shows no signs of acute coronary syndrome on ECG. You would need then to do chest X-ray for the patient. Is the chest X-ray diagnostic or not? If it is diagnostic, then you would need just to accordingly treat the underlying cause. However, if it's non-diagnostic, then you would need to do further interventions and assessments to try to reach the appropriate diagnosis and to form and establish a management plan. We will discuss then four scenarios. First one, if the patient showing STEMI. Second one, if non-STEMI. Thirdly, if the chest X-ray is diagnostic. And fourthly, if the chest X-ray is not diagnostic, at the same time, no ECG changes for the patient. So the first scenario is STEMI. ST elevation myocardial infarction. You will suspect this whenever there are features of myocardial infarction prescribed by the patient. For example, the chest pain is central and crushing in nature. It is radiating to the left shoulder or to the neck. Also, it's increasing with exercise and relieved by rest. After doing an ECG, you would need to look for the ST elevation, meaning the elevation of the ST segment above the normal line. Now, there are three types for myocardial infarction showing ST elevation. The first one would be inferior myocardial infarction. You see this ST elevation in lead 2, 3, and AVF, as shown in the strip. Lead 2, 3, AVF. ST elevation all over these leads. Now, second type is lateral myocardial infarction. You see the same ST elevation, however, in lead 1, AVL, V5, and V6. Now, the third type is anterior myocardial infarction. You would look for ST elevation in lead V1, V2, V3, and V4. The treatment for STEMI would depend on the time of the presentation for the patient. You have two scenarios. If the time of the presentation was within the first 3 hours after the pain started, then you would go for thrombolysis therapy with alteplase. However, if the patient presented after the first 3 hours and sometimes up till the first 4.5 hours since the pain started, then you would go for percutaneous intervention, meaning emergency catheterization. The second scenario is non-STEMI, non-ST elevation myocardial infarction. You would suspect this whenever there are features of myocardial infarction. For example, as we've already discussed, the chest pain would be central and crushing in nature. It would be radiating to the left shoulder or to the neck. It would be increased by exercise and relieved by rest. Now, however, when you do an ECG, there would be no signs of ST elevation throughout the ECG. In this case, you would need to order cardiac enzymes or cardiac markers, looking for the troponin mainly. And if the troponin is elevated, mostly more than 12 or 14, then this would confirm the diagnosis. In this case, the treatment would be to administer the appropriate anticoagulants. Our third scenario is if the ECG shows no cardiac causes for the pain, there is no change in the cardiac enzymes, and actually the chest X-ray is given hints toward the diagnosis. So here we have multiple diagnoses for chest pain caused by a chest or lung causes. We have pneumothorax, hemothorax, and pneumohemothorax. Also, there is a common cause, which is pneumonia. You will also build a better differential diagnosis based on the examination and the history taking. Let's try to discuss here the investigation point of view. So we'll do a chest X-ray and we'll try to discuss each one separately. Let's start with the most immediate life-threatening, which is pneumothorax. Now, pneumothorax, as you know, is an accumulation of air within the pleura, and it might compress the lung. So you will try to look for the lung borders as indicated by the arrows. This would be the lung border, right? So this is actually compressed by the air. So this would need immediate needle decompression placed within the second intercostal space according to the affected side. And as a definitive management, you would need to insert a chest tube. This would be done by the specialized team. Now, the second one would be the hemothorax or accumulation of fluid within the pleura. Now, we'll try to look for an opacity with a curve pointed upward toward the axilla. This would give a hint toward accumulation of fluid. To make sure that it is blood, uh, like by monitoring the patient, if you see any signs of low blood volume when monitoring blood pressure and heart rate, this would give a hint. Another possible option is to try to evacuate this accumulation, and then you would build a better idea whether or not it's only fluid or it's only blood, right? So thirdly, we have both hemopneumothorax. Now you can see the opacity here. This indicates accumulation of fluid. However, there is no upward curving, and actually the air within the pleura is compressed in the lung. So there you go. You have now hemopneumothorax. So this would be need definitive management by inserting a chest tube as well. The fourth scenario is actually pneumonia. Now, pneumonia is an infection within the lung parenchyma. You will see a consolidation within one of the lungs loops, right? So this would also be needed to treat it with IV antibiotics and continuous monitoring for the patient to eradicate the infection. Lastly, our fourth scenario would involve if the patient shows no signs of cardiac causes on ECG and shows normal chest X-ray. In this case, you would need to do further assessment for the patient to reach an accurate diagnosis. For example, you need to exclude pulmonary embolism, like doing D-dimer for the patient, and most accurately to do CTPA, which is CT pulmonary angio. You need also to do a cardiac enzymes or cardiac markers, as we've already discussed. You need to exclude pericardial effusion or pericardial tamponade, particularly because it could be life-threatening. This would be done by doing fast scan for the patient, placing the probe on the epigastrium, directing the probe upward to look for any fluids accumulated within the pericardium. Definitive treatment for pericardial effusion or pericardial tamponade would be pericardiocentesis performed by the specialized team. Lastly, to exclude aortic dissection, you would need to perform a CT scan on the chest and to refer the patient for the appropriate theater. So today we have learned how to follow the right approach for a patient with chest pain to reach an accurate diagnosis, provided that the patient is maintained stable and safe, to refer the patient to the appropriate theater for definitive management, and at all times to know your limits and escalate doubtful situations.